Can I confirm that you can see and read my screen, please?
Yes, we do.
Lovely. Thank you very much. And thank you once again for your kind invitation to join you. I've listened to the previous speakers with great interest, and in particular, the presentation on the medial coricoclavicular ligament, which is a very interesting subject and close to my heart. So I'd be delighted to join in a discussion about that particular bit of anatomy, which I agree is not that well appreciated, perhaps, and very probably quite important. But we're here to talk about clavicle fractures. When I started thinking about clavicle fractures a bit more deeply, largely in my role to do with the upper extremity expert group and trying to think about how we could improve clavicular plate systems, it was always a good idea to go right back to the literature and to the issues that matter to our patients. And in order to organize my thoughts, I created this matrix, this table, where things that matter to patients, like the overall function of their shoulder girdle, how it looks, how it feels in terms of irritability of the brachial plexus, and whether it is malunited or non-united and symptomatic in both cases. If I have treatment, what is the complication rate? And if there are complications, do I have to have another operation? And if I have to have another operation, am I simply going to be facing persistent pain? So what's the likelihood that I'm going to be dissatisfied with my clavicle fracture if I have an operation or not? And so we started to draw together some of these ideas. And from literature, we get some impressions about what outcomes are truly the case after non-operative management. We see that about half of patients are worried about how it looks. About a third of patients are concerned about some diminution in overall shoulder girdle function. And another third, that's a high percentage, will have symptoms if you ask them about brachial plexus irritability, particularly of the lower cord, the lower trunk and medial cord, giving symptoms into the forearm and the ulnar border of the hand. We also know that non-union can be symptomatic, and interestingly, malunion far less symptomatic, which is intriguing if you discount malunion associated with brachial plexus irritability or subclavian venous compression. Overall, the complication rate of non-surgical management of clavicular fractures is roughly 4 out of 10 patients will have trouble. But of course, they don't have the complications of surgery. So if you look at the people who've had surgery, at the time I wrote this, which was 3.5 years ago, we knew that patients with more anatomical shaped clavicles had better dash scores and better constant scores. But if you remove the factor of non-union from the non-operative group, then operative and non-operative treatment, according to Chris Robinson in Edinburgh, resulted in similar functional outcomes. I think that has now been challenged by our knowledge derived from randomized controlled trials, one of which was conducted by my colleague Philip Ahrens in North London, which has pretty clearly shown that surgical treatment of a clavicular shaft fracture will result in a more rapid return to work, a more rapid rate of union, and an increased rate of completion of union. and of course also a very much lower malunion rate. So our knowledge about the outcomes of clavicular fracture relative to non-surgical treatment is now that operative management probably offers an advantage in the majority of people. It is interesting that in the Edinburgh study of midshaft clavicle fractures with what was called wide displacement, that is more than 2 centimeters of fragmentary displacement, or multifragmentary comminuted fractures, particularly with angulation, shortening, and, as I say, comminution, was a 1/5 of patients had a non-union, which was symptomatic. Now, I should tell you, if you don't know already, and if you haven't visited Edinburgh, that quite a number of people in Edinburgh are smokers, and a fair number of people drink alcohol to excess. And both factors might be confounding factors in that high rate of symptomatic non-union. However, another study from Michael McKee and Emil Shemich's unit in Toronto have shown a complication rate of operative treatment amounting to something like 1/5 of patients, related to the accuracy of reduction and fixation. And we'll come to this in a short while, but that starts to build in the issue of surgical competence. Why do people with non-operative treatment become dissatisfied with their outcome? Well, it's to do with the shape of the shoulder and to do with the irritability of the brachial plexus. When the scapular position is displaced or abnormal at rest and during movement, and we've heard about the importance of scapular posture and movement with acromioclavicular joint dysfunction. Well, what does that mean for us? It means that non-union in non-operatively treated fractures generates most of the non-operative problems with brachial plexus irritation. And the fact that there is a lump at the end in the clavicle itself, or an abnormal scapular position leading to abnormal shape of the forequarter, is fundamentally linked to the decrease in overall function, not just an appearance problem. The brachial plexus is, as you know very well, intimately related to the upper surface and lateral border of the first rib, and the clavicle is bound to the first rib anteriorly through the very strong rhomboidal costoclavicular ligament, behind which the subclavian vein passes. And therefore, the relation between the medial clavicle and the first rib is fairly immutable. Where the clavicle goes, so does the first rib. Now, the first rib doesn't move very much, as you know. It goes as a bucket handle up and down. So the medial end of the clavicle essentially goes up and down with the first rib. Not so the lateral part of the clavicle if it's fractured from the medial part, and we'll come back to that. Malunion has consequences on the retroclavicular and infraclavicular space, and a study that we're doing at the AO Research Institute in Davos is trying to describe that change in the volume and shape of the retroclavicular and infraclavicular space during clavicular, as a result of clavicular malunion. We're partway through that project at the moment, but it's looking fascinating to see how, in the first place, the intact clavicle relates to the first rib, and we expect to be able to demonstrate some rather useful morphometry in relation to displaced clavicular fracture simulation. Why would non-union occur in the clavicle? Well, we'll talk about that in a little while, but it's to do, of course, with perfusion. Periosteal damage is the key because endosteal perfusion of the clavicle is relatively poor in the adult. There's a lot of information about the economic cost of operative treatment of most things, because economists and hospital administrators want to know why we're spending so much money. But there's not much knowledge about the economic cost of non-operative treatment, except that we now know that the return to work is slower in those with non-operative treatment by several weeks. And that must have an economic cost both to the individual and society. Well, we can make these assessments of current knowledge of clavicular fractures, but by and large, the literature allows us to say some very broad things. First of all, that in non-surgical treatment, overall, malunion and its associated symptoms of brachial plexus irritability and subclavian venous congestion and scapular postural abnormality is present in about 1 in 3 people with non-operative management of a shaft fracture. For non-union with symptoms, the incidence in non-operative management is roughly 4 in 10, and overall a complication rate for non-operative management of something like 1 in 2, if we ask for the symptoms. What can we do to change that? Well, first of all, we want to be able to predict which patients with a clavicular fracture might go to a non-union if we're choosing to do non-operative management. The features of the fracture that generate periosteal damage and therefore non-union include displacement, of course, not just translation of 1.5 to 2 centimeters, but also rotation, which is inevitable, where the lateral aspect of the clavicle rotates ventrally under the weight of the arm, thus rotating the scapula dorsally and laterally. It also leads to the idea that restoration of the clavicular shape is not only about restoring biomechanics, but also allowing stable fracture zone reperfusion. But we also know that the plates that we've used in the past are not perfect. There's a lot of hardware out there which is not anatomically correct, hasn't been thought through very well, and does not fit terribly well, which leads to reluctance to use it. And the main feature of clavicular fractures, which is the position and movement of the scapula, is extremely difficult to assess. We don't have a very good scapular functional assessment mechanism or score. So we're not really able to measure exactly what we need to. We mentioned the DASH score, which is probably the closest and most useful. The constant score is much more about rotator cuff function. So operative intervention for me is about the position of the acromion, i.e. the glenoid. In other words, the shape, length and alignment of the clavicle determine where the center of rotation of the glenohumeral joint is, and that's what we're aiming to restore. It's also about restoring this concept of the retroclavicular space and reducing the risk of poor perfusion of the fracture and therefore non-union or failure to unite in a good position. Here's an idea about the subclavius, and this relates to the lovely talk about the acromioclavicular joint separation, because that medial coricoclavicular ligament is an extension of the inferior tendon of the inferior border of the subclavius muscle, shown closest to the clavicle. Now, it's a muscle that's one of my favorite in the shoulder, the other being teres major for various reasons, but this one's interesting because it's the only muscle in the shoulder that's got its own nerve supply. And therefore, in one sense, in an evolutionary sense, it was really rather important. And we can talk about that in discussion if you like. But the importance of this, of course, is that if you fracture the clavicle and therefore allow shortening, or rather relative lengthening of that muscle, its action on the clavicle cannot be as useful as it was before. And its action is to decelerate the lateral end of the clavicle, as it were, as an antagonist to the trapezius. So the trapezius both bridges the acromioclavicular joint, though stabilizing it and contributing to stability, but also pulls, of course, the lateral end of the clavicle upwards and backwards, and that is antagonized through pectoralis minor and the weight of the arm and subclavius. If you disable subclavius by shortening the clavicle, then the effect of deceleration of the scapula is not met. And scapular movement is never normal in a non-union or malunion of the clavicle. The clavicle, as you undoubtedly know, has an interesting embryological origin, and its perfusion or its blood flow is related to the embryology. So it's basically the medial half and the lateral half have different blood supplies. From the point of view of the clavicle, the major part is periosteal, and you know that that is related to the insertion of pectoralis major and the deltoid. So if we strip these muscles during the course of dissection, we risk damaging periosteal perfusion if that is still present, which means that for me, the antero-inferior clavicular approach and plate do not personally make too much sense. The endosteal blood supply is flimsy, but mainly goes into the medial part. So if you look at a healing clavicular fracture, you'll see callus from the medial fragments and not from the lateral side. So a non-union will be generated more in the more lateral clavicle fracture, which is more of a challenge because the lateral clavicle has, of course, the curious curves. So if we're going to do operative intervention, we've got to be clear that we're going to minimize the risk of complications, which are largely about iatropathic neural injury and iatropathic vascular injury. There are case reports and frightening literature about the potential injury by overpenetration of the distal cortex when drilling and putting in screws to damage the subclavian vein. And indeed, people have died. But that's to do, I would suggest, with hardware and how it's used. That's to do, of course, with surgical technique. And that's where courses like yours and the AO courses teach safe technique with safe use of the implants. So how does internal fixation for displaced multifragmentary midshaft fractures give better patient-related outcomes? Well, when we're thinking about that, you and I in the clinic are unconsciously looking at the space behind and around the clavicle in terms of the plexus and veins and the suspension of the scapula. We then look for imaging to understand or predict the functional outcome with or without intervention. And rather than rely upon classifications to tell us which particular clavicle fracture to fix, my sense is that we should be looking at the anatomy and pathoanatomy of these difficult to assess spaces and the concept of scapular suspension, for which CT scans are probably the best option. Can we reduce the complication rates of operative intervention? And please remember, these ideas were forming in response to all these challenges in about 4 years ago. And since then, it's been our privilege to work in the AO and with Dupuis synthase to generate a new generation of clavicular plates in order to try to reduce the complication. We have used a number of technologies and a number of epidemiological studies, morphological studies, to look at the clavicle shape. And you will see a video now, I hope, illustrating this.
Using the process of cylindrical...
You might have to turn up your volumes.
Lucas and Hans-Rudolf...
Oh, excuse me. Let's do that again. We looked at a number of clavicle models. First of all,
Lucas and Hans-Rudolf produced 3D models of the...
If you can't hear that, I'll talk over it. We looked at three-dimensional models of 100 clavicles, and we made models of the, as it were, the greatest, largest clavicles, the smallest clavicles, and the middle-sized clavicles. And we decided we would describe what we would imagine to be the implant-preferred pathway for these clavicles. That is a pathway for a plate that did not damage soft tissues as much as most clavicle plates do. And for those, we then generated a series of curves with the average over the population of each clavicle, generating a linear model, which we called the implant-preferred pathway, the so-called region of interest from a computational point of view. And then we discovered some very interesting things. If you map all the medial ends of the clavicle, one on top of the other, so they match at the medial end, there is some overlap and some similarity in the medial curvature, but of course the lateral curve is different. It looks, of course, different. It's a different shape, a different curvature. And so if we start fixing a clavicle fracture medially, we have the problem of contouring a plate laterally or designing a plate to fit laterally. If you map or match the middle thirds of these lines, you get closer matching laterally and shortness of the similar medial anticurve with some differences in length. But here's the fascinating thing. If you overlap those models laterally, first of all, you see that the curvature of small, medium, and large clavicles is the same. And there is a very close match in the anticurve with simple shortening. So length in the clavicle is related to the medial anticurve, and the lateral retrocurve could be said to be almost, from a statistical point of view, similar, whether it's a small, medium, or large clavicle. Well, that's a very different concept to what we think of as the clavicle. Of course, this doesn't account for surface morphology, and we've done some more about that more recently. But that gave us some insight into how to think about internal fixation of clavicle fractures, the implant-preferred pathway. We can draw some conclusions and then have a discussion. Clavicle fractures were thought to be benign, but they're not. Non-operative management does result in a high instance of unsatisfactory outcomes. But our patients' concerns are not really very well measured by current patient-related outcome measures or scores. However, if we get clavicles healing as close to anatomic as possible, there is a drift towards better outcomes, and that is now being established through randomized controlled studies. If we do operate, most complications are related to hardware failure, so we've got to get the hardware right, or hardware abusive hardware, i.e. the vascular and neural complications. So better hardware design might overcome many of the issues that prevented us from being comfortable with internal fixation of clavicular fractures. And we believe that we're getting there with our current design of clavicular fracture plates, which are just about to be released for general use. So thank you so much for your overall attention